Hello everyone! Today we are going to talk about a disease that occurs in a newborn. A girl was born 3 days ago. The chief complaint is abdominal distension for 2 days. The prenatal ultrasound showed the polyhydramnios. The physical examination showed the abdomen is markedly distended, with visible loops of bowel. The radiographs of the abdomen showed multiple dilated bowel loops. So, what is the possible diagnosis? The possible diagnoses are intestinal atresia, stenosis, meconium ileus, HD, annular pancreas, intussusception, and malrotation. So, what to do next? Exploration laparotomy is necessary. During the operation, we found that ileal atresia was observed at a distance of about 100 centimeters from the Treitz ligament. The diameter of the proximal intestinal was about 4 centimeters, and the diameter of the distal intestinal was about 1 centimeter. Both the blind ends were connected by fibrous cords, so we did ileal resection and intestinal anastomosis. The final diagnosis was ileal atresia, type 2. So, what is intestinal atresia? Intestinal atresia is a congenital complete obstruction of the lumen of the intestine. It is one of the most frequent causes of bowel obstruction in the newborn, and it can occur at any point in the gastrointestinal tract. Duodenal atresia represents up to 60% of small intestinal atresias. Jejunal or ileal atresia each represents approximately 20% of small intestinal atresias, and colonic atresia is the least common type. Duodenal atresia is thought to be caused by an interruption of recanalization during normal gastrointestinal tract development in the first trimester. Jejunal and ileal atresias are acquired in utero, resulting from vascular disruption, leading to ischemic necrosis of the fetal intestine. Colonic atresia is the least common form. Findings on prenatal ultrasound that suggest the possibility of intestinal atresia include polyhydramnios, dilated bowel, or increased bowel echogenicity. Duodenal atresia usually has the characteristic double bubble appearance on prenatal ultrasound, which is similar to the postnatal abdominal radiograph. Jejunal and ileal atresias may present with polyhydramnios, ascites, dilated bowel loops, and increased bowel echogenicity. Colonic atresias are unlikely to be detected on prenatal ultrasound unless they are associated with additional more proximal atresias or other congenital anomalies. Intestinal atresia presents with symptoms and signs of intestinal obstruction, including abdominal distension and vomiting, sometimes failure to pass meconium. The type and timing of these symptoms vary with the location of the obstructing lesion. A supine antero-posterior abdominal radiograph and either upright, lateral decubitus, or cross-stable lateral films should be obtained in all cases of suspected neonatal intestinal obstruction. The main purpose is to confirm the presence of obstruction, estimate the segment affected, and assess for perforation as evidenced by pneumoperitoneum. If the plain radiograph shows signs of intestinal obstruction but no evidence of perforation, most infants should be further evaluated with an upper gastrointestinal contrast study. The main purpose is to rule out malrotation with midget volvulus, which is a true surgical emergency. Signs of malrotation on upper gastrointestinal contrast studies include low-lying or displaced duodenojunal junction and coiling of the bowel with partial or complete mechanical obstruction. The goal is to identify the site of atresia or to identify another cause of obstruction such as Hirschsprung disease or meconium ileus. Infants with this combination of findings should be taken urgently to surgery. Testing should occur prior to surgery. For infants with duodenal atresia, evaluate for associated cardiac malformations or Down syndrome. For infants with any small intestinal atresia, evaluate for vertebral anomalies. For infants with duodenal atresia, detect associated kidney anomalies. For infants with duodenal atresia and suspicion for Hirschsprung disease, rectal biopsy is important. The treatment of intestinal atresia consists of initial preoperative management followed by surgical correction. Preoperative management for an infant with intestinal atresia includes withholding feedings and placing a decompressive nasogastric or orogastric tube, establishing intravenous access and providing parenteral fluids, correcting any abnormalities in fluid and electrolyte balance, and giving routine perioperative antibiotics. The surgical approach depends on the site of the atresia. In every case, the possibility of a second or multiple atresias should be considered. After this study, can you summarize the major points of intestinal atresia? Thank you for your attention.